Hi, my name is Jenny Moran. I'm a pharmacist at Children's Hospital of Wisconsin. My primary area of work is on the oncology and bone marrow transplant unit, and I am board certified in pediatrics board specialty for pharmacy. My talk today is titled Pharmacology of Emerging Therapies to Treat Pediatric Cancers. During the talk, I will be talking about these 5 different groups of medications. My objectives for the talk for all of you is to have you understand the mechanism of action and pharmacology of each of the emerging therapies in cancer, to understand the theory behind their proposed use for the pediatric cancers they're being used to treat, and to understand potential side effects associated with each medication. As I talk about side effects, one of the things that I talk about with my pharmacy residents and pharmacy students is that as a pharmacist, I'm always looking for those side effects on rounds. For all of you as providers, you're thinking more about the disease state, whereas the pharmacist is thinking about the side effects. I'll talk to you today about figuring out which side effects are important for you to listen to as your patients are experiencing their therapy. One thing that I use to talk about is to say that a side effect is a natural expected effect of a medication. This can be either a desired effect or an undesired effect, depending on what you're using the medication for. For instance, if you have diphenhydramine that you're using to prevent itching from morphine, it may also cause your patient the side effect of the patient becoming drowsy or sleepy. If we instead wanted to use the diphenhydramine to help our patient fall asleep, then the side effect when treating itching from morphine would be a desired effect when you're using Benadryl for insomnia. In contrast to a side effect, a medication can also have an adverse effect, and this is an unusual, unexpected effect of the medication. This would be the effects that we are most concerned about and really need to monitor for as cancer providers. For the example of the diphenhydramine, a paradoxical excitation, which happens oftentimes in the pediatric world, would be an unusual adverse effect, and that is not something that we would want to happen. In the cancer world, we must always be looking out for these unexpected, unusual effects of our cancer treatment. During the presentation, I will try to emphasize the main wow side effects that I consider as these unusual, unexpected side effects to look for your medication. The 5 categories of medications we're talking about today are differentiation agents. Those are medications that affect the cancer cells by transforming the cancer cells into normal cells through their effect. Targeted therapies interfere with specific molecular targets to help stop the growth, progression, and spread of cancer cells. The epigenome targeted therapies are medications that affect 2 different areas of differentiation early in the cell cycle that causes the cancer cells to divide. We are presuming that these are DNA modifications or histone modifications, and the targeted therapy will affect this area. Immune checkpoint inhibitors are medications that prevent the patient's own immune system from being turned off by the cancer cells and result in the patient's own immune system attacking the cancer cells. Our anti-angiogenic agents are medications that inhibit the growth of new blood vessels, which help to slow or stop the growth of cancer. As we look at all of these agents, we can consider that our chemotherapy and radiation, which has always been the mainstay of cancer treatment in the past, is the small circle on this diagram. All of the other medications that I'll be talking about today and that you'll also hear about through this course are the other areas of treatment for our pediatric cancers. I believe that in the future, our pediatric cancers will have the chemotherapy and radiation as being only a very small component of their treatment. And although we'd love to have each of these medication classes I'm talking about today be the new and improved cure for our pediatric cancers, I don't think that'll be the case. What's going to be happening is that we're going to be overlapping all these medications and using them together to help our patients have the best outcome possible with the fewest side effects. Instead of separate circles, all of these will be combined and working together. For the beginning of our discussion, we're going to look at differentiating agents first. The research on differentiating agents has occurred very early in the treatment of leukemia in the early 1970s. At that point, it was discovered that the leukemia cell's development stopped early in the disease at the time of cell production, and differentiation was prevented for the cells to go to normal mature cells. Therefore, a medication class that could stop the cancer cells from growing unstopped, the medications that could encourage the differentiation to mature cells would help to stop the disease. One of our biggest examples of this is L-trans-retinoic acid that's used for APML therapy. As we look at this chart from Chen Cancer article, they look at cancer as being treated by traditional chemotherapy, as we all think about it, surgery, radiation, and chemotherapy, as the cancer being killed, but also the patient somewhat being killed or hurt. And the differentiation therapy that was discovered in the early 1970s, we were hoping that the patient would be able to have a medication that would affect the cells moving towards mature cells, and that the patient and the cells would now be normal. Differentiating agents of L-trans-retinoic acid and arsenic trioxide are some of the earliest cancer treatments that were being used for APML treatment specifically. It was found that L-trans-retinoic acid could stop the differentiation of APML, or produce the differentiation of APML during their in vitro experiments. After it induced remission in all of its patients in the first clinical trial that was used, and it was really exciting. Unfortunately, after initiation of combination therapy, it was found that leukemia cells quickly developed resistance to ATRA. Therefore, arsenic trioxide was discovered to produce remission in relapsed patients, and arsenic trioxide helps also to promote partial differentiation, and it also causes apoptosis of APML cells. Historically and currently, the discovery of ATRA and its use as a differentiation agent, along with arsenic trioxide, occurred over 30 years ago and still remains the most successful use of differentiation therapy. So when we look at L-trans-retinoic acid, we've talked about its mechanism of action a little bit, in that it hits the retinoic acid receptors, we believe, to aid in decreasing their proliferation and to cause our cancer cells to differentiate into normal cells. L-trans-retinoic acid is part of the REMS program due to the effect on maturing fetuses during pregnancy. So as a provider for cancer patients, a provider must be part of the REMS program, and the patient must get their medication through specific medication distributors that are part of the REMS program. This means if your patient is inpatient, they will have to use their patient's own supplied through the REMS program, and the hospital would not be able to supply that medication. I will be talking about REMS programs in relation to other medications in the future part of this presentation too. For APML treatment, one of the biggest side effects or wild side effects that you have to watch for is differentiation syndrome, or L-trans-retinoic acid syndrome. It can occur in up to 25% of your patients. In those patients, you're really going to have to think about possibly needing to use steroids to treat that complication, and the patients end up with capillary leak syndrome and accumulation weight gain, and oftentimes respiratory distress that can progress to full multi-organ failure if the if steroids are not used early in the treatment. The other possible complication is rapid leukocytosis, which occurs mainly in the CLL patient or in other populations, but can be a problem for this. And again, what you want to do is start high-dose steroids. The next medication that we're talking about is arsenic trioxide, again used for APML, as I talked about earlier. And for this medication, emetogenicity is a problem, so oftentimes your patients will need to take an antiemetic before, and QTc prolongation can also be a problem, and that should be monitored weekly during therapy. The therapy for APML tends to be long, so this is something you always have to keep in the back of your mind. The other thing is that it can affect electrolytes, especially causing low potassiums and low magnesiums. So the electrolyte monitoring should occur, since that will cause a potential for QTc prolongation if those are low. You also can worry about pseudotumor cerebri. So if your patient has a headache, you need to look further into that. The last medication that I'm going to talk about as a differentiation agent is isotretinoic acid. And that one is used actually in neuroblastoma treatment. This one was originally thought to be able to help us cure neuroblastoma by itself. But it was found, even though it can induce differentiation in neuroblastoma cells to normal cells, it has oftentimes resistance that occurs and cannot be used as a single agent. Isotretinoin, also known, you may remember it as being Accutane, does cause all the dermatologic changes that we think about that occurs for Accutane, which is dry skin, peeling skin, and you can use emollients to help with that, and it can also cause like dry eyes and things like that. Headache is also pretty common with it, and you do want to watch out for some of those pseudotumor cerebri symptoms that I talked about earlier. There has also been known that there can be long bone changes with this medication too. Something to watch out for. If you remember, the isotretinoin and the L-trans-retinoic acid are all vitamin A derivatives. So you can see that our patients oftentimes are looking for vitamins to help them, and we can say in certain cancers we can use vitamins to help treat them. The next area that we'll talk about with differentiating therapy is that there are overlap between other therapies I will be talking about today. The epigenetic modifiers, azacitidine and decitabine, help to differentiate AML and MDS cells into normal cancer cells when they're used. Histone deacetylase inhibitors, such as virostat, also help to promote the differentiation of leukemic cells into normal cells and can also be thought to be used for solid tumors. Tyrosine kinase inhibitors, such as gemcitabine and erlotinib, have often also been shown an off-target effect to promote differentiation of cell lines in AML and solid tumors to normal non-cancer cells. In addition, we have done studies to look at other vitamins besides vitamin A as differentiation agents. Vitamin D has been proposed as a strong potential, but has failed to show positive effects in clinical trials at this point. The research for further differentiation agents is ongoing, and we are hoping that these will also provide minimal side effects to normal cells. One of the charts that I found in my research for this presentation showed this timeline of differentiation agents throughout from the 1970s to now. And I included in the presentation out of interest for you to look at, because it does help us to see some of the history behind it. Next, I'm going to go on to talk about targeted therapies. Targeted therapies, we want them always on that bullseye on target. And we will show how this is true for some medications, but also not true for others within the targeted therapy realm. When targeted therapies were first looked at, and that again was many years ago, over 20 years ago, we were really hoping that these medications would be able to interfere with the specific molecular targets that we were looking at to stop growth and progression of cancer. We now have new understandings of molecular targets because of all the genetics availability that we have for our cancers. And each day, new therapies are being discovered. This really gives all of us a challenge as we try and stay up to date on these therapeutic entities that are available to treat our patients who have pediatric cancers. Targeted therapies really have a huge impact on pediatric cancer outcomes, especially in terms of event-free survival with reduction of short and long-term toxicity that's caused by regular cancer treatment. All of us know this pretty well, but I think there will be even more differentiation of our patients into multiple different types of therapy depending on the molecular profiling in the future. This chart is showing how our molecular profiling will give us prognostic markers And some of these predictive markers will also tell us about drug sensitivity and resistance, and possibly also predict some of the outcomes in the form of adverse effects that some of our patients may have. So as we are looking at the molecular profiling of our patients, we're not only doing it for the treatment of the disease, but also for the use of specific medications for our patients. And we may find that certain patients will not get a medication completely due to the fact that they would be at risk for high adverse effects for it. As we move into talking about the specific targets for targeted therapy, we all know that they are tyrosine kinase receptor inhibitors for the most part. The tyrosine kinases are transmembrane proteins, and they help to catalyze transfer of phosphate in the form of ATP to tyrosine residues and polypeptides. We have over 30 years of experience in identifying these tyrosine kinases, but as all of you know, it's more recent that we are using them in multiple perspectives of pediatric cancer treatment. In the first few slides of this section, I have included some of the main pediatric biomarkers for tyrosine kinase inhibitors that we are using today. I was amazed in my research for this presentation that I learned about so many different receptors that I had not realized there were. As I made my chart for this, I went from 1 page of a list of receptor markers to 2 pages on to 3 pages. So there are many receptors that we are looking at in the form for targeted therapies. And remembering these is kind of hard. We're used to saying, oh, it's a JAK inhibitor, but we may not realize that it's the Janus-associated kinase inhibitor as we move away from our school time period. So I have these listed. I will be talking about them a little bit as we talk about each medication. So the tyrosine kinase inhibitors are enzymes that catalyze the transfer of that phosphate group. We know that there are receptor tyrosine kinase inhibitors and non-receptor tyrosine kinase inhibitors. These inhibitors have been identified as over 90 tyrosine kinases at this point in time. They are all mediators of the signal transduction processes within the cells. These tyrosine kinases seem to block activation of various signaling pathways through inhibiting the receptor tyrosine kinases and then competing for binding sites on the ATP of the kinase. In this way, they activate proteins and molecules within the cell to help promote cell differentiation, cell growth, and also help promote apoptosis possibly in the cells. We don't completely understand how these tyrosine kinase receptor inhibitors are working to help treat our cancers. And most of the predicted mechanisms of actions are only a minute part of them. And I will talk about that as we go on. Imatinib is the first tyrosine kinase inhibitor that I will talk about today. Most of you are very familiar with this. It is the first one that came on the market and was the most exciting breakthrough for pediatric and adult cancers, specifically for leukemias. In patients that had Philadelphia chromosome positive cancers, it was found that this could inhibit the BCR-ABL tyrosine kinase and block the proliferation and then induce cell death in patients that were Philadelphia chromosome positive for CML and for ALL. Once we were able to use imatinib in our pediatric patients, we were finding very good outcomes in these patients in oral medication, which was very unlike the other therapy that we needed to use for our ALL patients, and one that had very few side effects. The side effects monitoring that we're talking about for this particular medication does include the bone marrow suppression still. It also causes a moderate emetogenicity, and most of my patients, at least, we give an antiemetic before they take it, and also try and have them take it at bedtime if possible. Skin rashes are not uncommon with it, and in the long-term effect, we also look at thyroid function and the potential for pulmonary changes for this medication. As we started using imatinib to treat pediatric ALL, for Philadelphia chromosome-positive patients, we unfortunately found that there were a lot of resistance that occurred. So the imatinib worked for a while, but could not have prolonged good outcomes. The Dasatinib was developed because it also inhibits the BCR-ABL tyrosine kinase, but is more specific for the resistant mutations that occur for imatinib. And it binds to both active and inactive ABL kinase, and it has other effects too. In its use for the treatment of Philadelphia chromosome-positive ALL, we also see that bone marrow suppression. We don't see as much nausea vomiting in it, but we do see some diarrhea that can be very severe. So we need to watch for that in our patients. The other thing for Dasatinib that's important, and you'll hear this message later on too as I talk about other medications, is that it can cause QTC prolongation. So monitoring for those QTCs is always something you need to keep in mind. And then arthralgias and myalgias do occur in some of our patients, and sometimes that can be dose limiting. Again, we are also looking for the pulmonary toxicity. Growth retardation is a concern, but really most of our therapies will cause that. But so that's not something that we have to really be that concerned about, because we're trying to provide our patient with good quality of life in the future, and the growth retardation is not something we'll have to watch for as much. The next medications that we're going to talk about within the tyrosine kinase receptor inhibitors are multi-kinase inhibitors. What's so great about these is that they are attacking the tyrosine kinase from multiple directions. And that means that we are having good outcomes without much resistance for these medications. Sorafenib is one of them. In addition to its inhibition of growth and angiogenesis inhibition, it also hits some of the other kinases that are cell surface kinases, including the vascular endothelial growth factor receptor 1, and actually multiple receptors in that group, and also the FLT3 receptors. At this point, one of its biggest use in the pediatric world is for FLT3 positive AML. But we are also seeing that it's going to be used in multiple other areas due to all of the areas that it can be used in inhibit. Common side effects with sorafenib include flu-like symptoms, so that would not be unusual for your patients, including fatigue. It does have that high emetogenic potential, so you need to use antiemetic before it. And then the other thing that can be severe is the hand-foot syndrome associated with it. This especially occurs in the first 6 weeks of therapy, and we are finding that we really can use emollients, topical emollients, to help with that side effect of the sorafenib. Next, we're going to talk about crisatinib a little bit. This is an exciting medication specifically that we can use for patients that are ALK positive for their neuroblastoma. We do not understand its place in treatment yet, but we are looking towards future clinical trials to see where it will fall. Crisatinib also has a moderate emetogenic potential. We do see some dizziness in our patients and also some neuropathies, and QTC prolongation is also a problem. As we move into crisatinib with its other areas of inhibition, we are seeing some liver dysfunction and renal dysfunction for this medication too. Crisatinib is a tyrosine kinase inhibitor that reversibly inhibits the endothelial growth factor receptor. We do not know exactly where it will be used in pediatric cancers. Its biggest use right now is in malignant gliomas, but we are also hoping to be able to use it in solid cancers in the pediatric realm. This medication does cause arthralgias. Some pain is also associated with it, and fatigue. Some of our patients are developing some conjunctivitis with it, and that may not be severe, but is something to be aware of. And that may be involved with the decreased tear production, but we're not sure. There's also renal failure associated with this, and another thing to be aware of is the potential for radiation recall if any of your patients in our future treatment plans for it have had radiation before. The long-term effects that you hear about for long-term cancer survivors, we also are looking at possible thyroid effects for this. So that may be a concern. And there have been some patients that are reporting some psychiatric concerns, such as depression and anxiety increasing when they're on this medication. Relaxinib is a JAK1 inhibitor, JAK1 and JAK2 inhibitor, and we are very excited to see some of its use for specific patients who have JAK1 positive leukemia. We also think that this medication may work in other cancers, and clinical trials, again, are just beginning with phase 1 trials for this medication. For relaxinib, we still are looking at hematologic toxicity potential with it. It does seem to be causing diarrhea for some of our patients, and long-term we are worried about liver toxicity for this medication. So we may need to monitor for that. A number of patients are seeing unusual infections, including urinary tract infections too, which may be related to it. For hematologic toxicities, it may be a reason that we'll have to hold the medication, so you may need to monitor for that. Our next medication we're going to talk about is poziotinib. This one, we are really excited for potential use in soft tissue sarcomas. Again, it is another multi-kinase inhibitor, having very many different effects within the body, including potential immune system effects too. Side effects for the poziotinib include hypertension, so that may be a concern. There's also other renal effects that affect electrolyte abnormalities, so you may need to do some electrolyte monitoring for your patients. And we are concerned for poziotinib for the long-term potential for hepatotoxicity and that QTc prolongation too. In addition, for poziotinib, we are concerned about wound healing, and that will come up later as we talk about other medications too. That wound healing can affect if your patient needs to have surgery. So it's something to look at if you need to hold it for that time period. Next, we're going to talk about the medications that we think about for using for solid organ transplants, such as renal and liver transplants. Sirolimus is an mTOR kinase inhibitor that seems to help to inhibit T-cell activation and proliferation. Its use in renal and liver rejection is known, and we are also using it in some solid tumors and also in MDS and AML treatment. Sirolimus side effects we can kind of think about is along the lines of the calcineurin inhibitors that we use to prevent rejection, which includes hypertension, changes in potassium levels, and wound healing impairment is a concern for this. And we will hold the sirolimus at my institution if we are concerned if the patient has cellulitis or some type of infection. In addition, there are some long-term concerns for interstitial lung disease, renal toxicity, and liver toxicity. As we move to everolimus, again, it's a macrolide immunosuppressant, mTOR inhibitor. So it does have a few other pathways that it will use. It's been well known for use in breast cancer and other adult cancers. And in the pediatric world, we're looking at its use for Hodgkin's disease in addition to the brain cancers, leukemia, and some solid tumors. It, again, is similar to the calcineurin inhibitors that we may have to look at blood pressure changes and electrolyte changes, and can have long-term liver toxicity and renal toxicity, lung toxicity. Those are still being looked at because its use in pediatric cancers is so limited right now, so we'll have to see how this turns out in the future. So what's our future for targeted therapies? One of the things that many of you know is that targeted therapies right now, for sure in the adult world and pretty much in the pediatric world, have fixed doses. That means that we're prescribing one dose and not changing that dose based on anything having to do with the patient. In the future, I think a big area for targeted therapies will be monitoring drug levels for these, and there are some articles out about that at this point in time. And that's because these medications, we'd like to minimize their toxicity, but especially in the pediatric world, we are finding that we may be using too low of doses for our pediatric patients. Relaxinib is an example of that. The pediatric studies are using doses much, much higher than the adult studies were using. The other thing about looking at monitoring drug levels for these medications is that we do know that there are some drug interactions that are occurring based on stomach pH and affecting bioavailability. and there are also some cytochrome P450 effects of the medication. And those effects, when we start using them with interacting drugs, it would be great to be able to use drug monitoring to help us determine the best dose for this. I'm thinking about targeted therapies in the next 2 years or so of coming up similar to voriconazole monitoring that we're using for the antifungal agent voriconazole, that we're going to find that we're going to be using very individualized doses for these medications. And many of your institutions may be doing this already. So as we are looking at these targeted therapies, we're really excited that they have a great promise for cure for many of our patients, especially as we identify certain genetic profiling for our patients. The one thing that we're finding, though, is that as great as these medications are, we're also finding bad off-target effects. What that means is that we're seeing side effects that we didn't expect from the medications, and we don't really know why because we don't completely understand the mechanism of action for these. As a result, right now, about 90% of the medications that are in the targeted therapy tyrosine kinase receptor inhibitor area that have been discovered are now not part of standard therapy due to toxicities. So they've been taken off the market either due to toxicities, lack of efficacy, or lack of improvement over the current chemotherapy agents that we have available for that disease state. And that is a little bit of disappointment for all of us. So like I said, not all of our response for these medications are on target and they are off target. Sometimes for good things. So some of them we're finding, oh, this off-target use is really positive for a different type of cancer than we expected. But there's also the side effects that are a problem. Next, we're going to move on to epigenome-targeted therapies. Epigenome-targeted therapies is the study of the mechanisms that turn genes on and off. What's really exciting about these therapies is that these medications affect gene expression and decrease uncontrolled cancer growth by alterations in proteins that regulate cell cycle progression, apoptosis, and cell survival. These epigenomic changes are the basis for many pediatric cancers, especially hematologic malignancies, and may help us to have another weapon in our pocket to help treat these hematologic malignancies, and especially when we're seeing refractory disease. There are 2 drug classes considered for epigenome therapies. Those 2 drug classes are the DNA methyltransferase inhibitors and the histone deacetylase inhibitors. The changes in the gene expression on these help to promote tumor proliferation and impact tumor response. And by using these drug classes, we are hoping to prevent that. There are 4 FDA-approved medications in the epigenome targeted therapy class. So let's first look at how they actually work. So for epigenome, as a patient's cancer cells start to proliferate, we know that DNA methylation is involved. In the normal cells, there's a CpG island in the promoter region, which is thought to be hypomethylated, and this allows for gene transcription. What that means is that gene suppressor molecules are activated and prevent the normal cells from taking off or dividing too much. In cancer cells, we find that the CpG island in the promoter area is hypermethylated, and this inhibits the tumor suppressor gene and allows for the cancer to develop. Our DNA methylator inhibitors will help to suppress these hypermethylated areas and allow the gene suppressor to be activated again and prevent the cells from dividing too fast. The DNA histone modification part of the epigenome therapy is looking at the histone part of the molecules. We know in a normal cell that the acetylated histones open up the chromatidin, and the genes are then switched to they're switched on so that the genes don't divide unprotected. In the cancer cells, the deacetylated histones cause closed chromatidin, and the genes are switched off, and therefore the cancer is able to divide quickly. The histone DNA inhibitors will help to prevent this turnoff of these genes and will help to prevent the cancer from dividing so quickly. So the epigenome, as we talked about, is one. The DNA methyltransferases is one group of the enzymes, and these add a methyl group to cytosine bases. It's thought that the methyl group is added within a promoter area of the tumor suppressor genes, and that helps to silence these genes. This causes the cancer cells, if the gene suppressor is silenced, it causes the cancer cells to proliferate uncontrolled during cancer growth. If we add the DNA methyltransferase inhibitors, which is a cytidine or decitabine, which will prevent the methyl group addition, then the tumor suppressor genes get turned back on and the cell's growth is put in check. Decitabine is one of the medications. We're using it especially in hematologic malignancies such as AML and MDS. It does cause a moderate immunogenic potential, and it will cause hematologic toxicity since that's its main area of target. Our patients are also seeing some potential for tumor lysis syndrome if the tumor burden is high for the AML at the start of therapy. And we are also seeing some myalgias and arthralgias that can be very severe for some of our patients, requiring some medications to treat, including morphine. We also do see some pulmonary changes, and we are seeing some CNS changes such as depression and anxiety for these patients, and also insomnia. The pulmonary changes tend to start out with a cough, so that would be something to watch for your patients. The next medication that we'll talk about in this group is decitabine. Decitabine works in a similar way and also helps to kill the rapidly dividing cells. One of the things that I didn't talk about yet for these epigenome-targeted therapies is the original place that they were used was for cancer treatment as chemotherapy agents. Many of these, including decitabine, was originally used at much higher doses to try and kill the cells. But what we find is if we use these at lower doses, we can have the epigenome target affected without causing as many side effects. As we look at decitabine to talk about side effects, we are still looking at that hematologic toxicity, but we are also looking at some renal effects that seem to cause changes in electrolytes, so you will want to monitor for electrolytes in these patients. And decitabine, just like acidamine, we're also looking at some of those pain areas, including backache for decitabine, arthralgia, and limb pain. We do see some blood pressure changes as we're giving this medication, so that's something to watch out for. And infections is a big concern too. As we move on to the histone deacetylase inhibitors, these histones are proteins that put the DNA into nucleosomes and help the DNA to wrap around the chromatin within the nuclei. The histones can be changed by acetylation, which allows for the chromatin structure to change, which I talked about earlier, and this will promote active transcription. It's believed that the histone acetyltransferases are overexpressed in certain cancer cells. And then cell regulation, cell differentiation, and tissue development occur without any blocking of that in the cancer cells. So if we can use the histone deacetylase inhibitors to block this activity, we will help to promote the gene silencing, and the cells will no longer differentiate into cancer cells. Next, we are going to look at the vorinostat or the romidepsin, which are our two histone deacetylase medications. Vorinostat helps, as we talked about, with the inhibition of the histone deacetylase. And there are other changes that affect too, again, as I talked about at high dose, which can also cause apoptosis of cells. Its primary use right now is for lymphoma, and in the adult world for advanced melanoma. We are concerned about hematologic toxicities as well as QTc prolongation for the vorinostat. And we also are looking at renal toxicities, which also may affect electrolytes, causing peripheral edema too. Patients sometimes do have some chills and fatigue with this medication and severely could have diarrhea, so that's something to watch out for. Long term, we are also seeing some liver toxicity too. So romidipsin is another medication in this group, and this one also has some areas where at higher doses it can be used to as more of a chemotherapy type agent as opposed to just epigenome targeted therapy. It's used mainly for the lymphomas, and hypersensitivity reactions are not uncommon with it. Along hematologic toxicities are known in its primary effect too. We do see also those blood pressure changes and the renal changes causing electrolyte abnormalities. We also have seen the cough associated with it and EKG changes, so that's worth it to watch for your patients. And we do see some unusual infections, including EBV reactivation. So epigenome, I want to just mention again that we are using it at lower doses. And I will talk later on about how we may have to look at clinical trials that actually look at the timing of those epigenome medications in our patients so that we get them at the right time in their cancer treatment along with other medications. Next, we're going to move on to our immune checkpoint inhibitors. These medications are the ones that we are seeing a huge talk about in the news, I would say. And that's partially due to the T-cell therapies that are now becoming available, but also all of us are really excited about the potential to use the patient's own immune system to help turn off those cancer cells and help the patient's own immune system attack the cancer cells. It is often the case that medications that we are looking at have been studied extensively in adult cancers and not very much in pediatric cancers. For immune checkpoint inhibitors, we are finding that there are very few long-term, long-lasting effects in the pediatric cancers, and we're trying to understand why. The difference in the efficacy in pediatric cancers seems to stem from the fact that in the adult cancer world, the immune checkpoint inhibitors are very highly effective in cancers which have more than 100 mutations per exome. Most pediatric cancers have are as low as only 0.1 mutation per exome. That is obviously a huge difference. So why is that? It's felt that adult cancers are a part of a chronic inflammatory disease that has been happening or going on for a long time. So there's a long chronic inflammatory effect phase of years prior to the cancer diagnosis. Whereas in the pediatric world, we believe that the pre-cancer time period is only a few weeks to months. As a result, the immune checkpoint inhibitors in the peds world still have to establish where they're going to be used. But there are certain cancers that it is working for. The mechanisms used to stop the T-cell suppression that the cancer cells use to hide themselves from the immune system include effects on the cytotoxic T lymphocyte antigen number 4, programmed cell death ligand protein 1, programmed cell death ligand 1, lymphocyte activation gene 3, and many more. As we're looking at these, let's look and see how these are having the effect. So as the T cell is trying to recognize the tumor cell as foreign, what the cancer cell is doing is producing PD-L1 and PD-L ligand 1 binding that inhibits that T cell from actually attaching to the tumor cell and prevents it from recognizing that tumor cell as foreign due to that blockage. So in this diagram, you can see how the PD-L1 and PD-L1 ligand are having an effect, preventing that T cell from actually doing its work on the tumor cell. For immune checkpoint inhibitors, what we're hoping is to put block that receptor at the PD-1 and or the PD-L ligand 1 site and allow that T cell to attack that tumor cell and cause cell death. The immune checkpoint inhibitors that are out right now, we do know there are a few monoclonal antibodies with pediatric potential. including ipilimumab, which is a CTLA-4 inhibitor, nivolumab, which is a PD-1 inhibitor, pembrolizumab, which is a PD-1 inhibitor, and there are a few others. We also have indexumab, which is the IDO, which is oftentimes starting to be used in some brain tumors too. This chart helps us to see some of the areas that these medications may have a potential use in peds. As I said, almost all of them have great established use in the adult world, but do not seem to have a use in the pediatric world, no one for sure at this point. We are excited for ipilimumab to be possibly used for some of the leukemias in the pediatric world, possibly osteosarcoma, and maybe some of the lymphomas. Each of the other ones have areas that we're looking at in clinical trials, and there are many phase 1 and phase 2 clinical trials for these medications out there. As we move on to looking at these medications specifically, ipilimumab is ongoing research again, as I talked about earlier. We are concerned for the immune checkpoint inhibitors for a number of areas. And there's a great article that just came out recently to talk about some things that we have to check long-term for the immune checkpoint inhibitors that have included in the bibliography for the course. These long-term things include endocrine effects and also effects on long bones, adrenal effects, and possibly some liver and renal toxicity. One of the things about the immune checkpoint inhibitors that we know is that we are concerned about the potential that these medications may cause some autoimmune disorders. So as you look at these side effects, we are noticing that they are having some colitis effects and other effects, as I talked about earlier, including some weird effects, maybe encephalitis, maybe some liver toxicity, and these may be autoimmune related. So as you're using the immune checkpoint inhibitors, you're really watching for anything unusual to be happening to your patient. And the thing we'll talk about later on is then we will need to possibly use steroids to treat these effects. For the nivolumab, what we're looking at is its use in pediatric research and also looking for immune-related adverse effects for these, which can be fatal. And also severe colitis, liver toxicity, renal toxicity. Also, it does have a myocarditis that may be associated with it, and that may be specific to some of the cells that it affects that are in the cardiac area or in the muscle of the heart. Pembrolizumab also is a PD-1 receptor inhibitor, and it is being used right now very well in some of the pediatric lymphomas, especially immunotherapy large B-cell lymphoma, and we're hoping to find uses in other areas. As you can see, the adult world has a whole slew of areas that it's being used in right now. Pembrolizumab has a number of phase 1 and phase 2 trials going on, but again, we are really looking for some of those autoimmune toxicities, including possible colitis, and then eye toxicities, lung toxicities, liver and renal toxicities. Unfortunately, you're seeing that some of these are affecting a lot of areas of the body, and what we were hoping for immune checkpoint inhibitors is that they would be few. The biggest thing to think about is the effects that they're having in the rest of the body are those autoimmune type diseases. So, severe, possibly life-threatening immune-mediated reactions can occur, and we would need to use corticosteroid treatment pretty early on to try and reverse that. The other thing about its effects in the pediatric world for the immune checkpoint inhibitors that's limiting its use right now is that sometimes these effects on the body may occur days to months after the medication is treated. All of us are well aware of the long-term survivorship trials that are going on and the information that we're finding for our pediatric patients in the long term as they move into adulthood. I think one of the things for the immune checkpoint inhibitors that may affect their use in the pediatric world is we obviously don't want to cause a problem that's going to be lifelong for our pediatric patients unrelated to the cancer, such as immune-related disorder. So what's the future of these? There are an explosion of trials right now that began about 4 years ago for these medications. I think time will tell for these whether or not they're going to work or if the dose-limiting toxicities are too much. And really, for the immune checkpoint inhibitors, really think steroids to treat. And I would say, again, that we're going to see agents come and go. The final group of medications that we're going to be talking about today are the anti-angiogenic agents. These are the medications that we're using to stop the growth of new blood vessels and therefore hope to stop the growth and or kill the cancer cells. As we look at these medications, we're looking at the process for which this occurs. To remind you, the basics of the angiogenesis process are that we have pro-angiogenic molecules. An example of this would be the vascular endothelial growth factor, which hopefully you recognized on a number of the slides earlier as our medications having an effect on in our other areas. Pro-angiogenic molecules present normally in adults only for wound healing and for menstrual cycles. Otherwise, they were not present in the adult world. They are abnormally present in the adult world in diseases, however, such as arthritis, diabetic retinopathy, and obviously in cancer progression, which is what we're most concerned about. These are the molecules, again, that are promoting the blood vessel growth. In addition, part of the angiogenesis process are the anti-angiogenic molecules, such as tropospondin 1. These molecules help to balance the blood vessel growth and help to keep the blood vessels stable without actually growing. So when we talk about anti-angiogenic agents, it's important to remember within the cancer system, there's an angiogenic switch that occurs. And that switch is that the cancer cells are actually shifting the system to pro-angiogenesis. This occurs because hypoxia occurs in the tumor. Once the tumor cells are more than 2 millimeters away from a blood vessel, the cells become hypoxic. It's the theory that this hypoxia causes the shift to pro-angiogenesis because those cancer cells want to have more oxygen. The hypoxia tells the tumor cells to release pro-angiogenic factors. These pro-angiogenic factors, which I'll show you in a second, help to make changes in the vessel's basement membrane that makes them permeable to new blood vessel growth. More of these factors come into play and then cause endothelial cells to migrate to the area to form lumen structure, parasites arrive, and then the neovessels are growing. These neovessels help to bring nutrients to the tumor cells, which increase the tumor cells' growth. The proangiogenesis that occur within the tumor cells also help to create a hypervascular area. The only thing is, because the tumor cells are growing so fast, all they want is nutrition and oxygen. So they grow very quickly, but also not in the normal way that they would for normal wound healing. So these blood vessels become dysfunctional, and they leak, and they also have increased permeability for other substances. As I said before, the anti-angiogenic agents work as the tumor grows beyond 2 millimeters in size, because then the tumor must develop its own blood supply. So until the tumor is that big, our anti-angiogenic agents will not be working. In this diagram, you can go over this later on. We're showing that there is that the blood vessel cells are saying, hey, I don't have enough oxygen. That cells components to make the blood vessel permeable. And with that blood vessel being permeable, other cells come forward and cause the growth of blood vessels. As those blood vessels grow, parasites come to form the tissue. And then as more hypoxia occurs, we're going to have more expression of vascular endothelial growth factor by the tumor cells, and that will make this whole process go again and allow the cancer to grow uncontrollably with good blood vessel nutrients being brought to it. So for the anti-angiogenic agents, there are three main categories of them. Monoclonal antibodies act as angiogenesis agents by blocking the vascular endothelial growth factor, and it blocks it binding to its receptor. The tyrosine kinase inhibitors are the most common medications in this group, actually. So again, I was talking about that overlap of medications from the groups I talked earlier. And these act as anti-angiogenic agents by inhibiting the formation of kinases that are required for that angiogenesis to occur. And then we do have a bunch of miscellaneous anti-angiogenic agents, which are being researched to be used in conjunction with some of our other medications. And for the most part, the mechanism for these are not completely understood. So as we look at the first agents, our first one that came out, bevacizumab, is the monoclonal that was used to decrease vascular endothelial growth factor and inhibits microvascular growth in all tissues. It was very exciting when this came out, and for some cancers, it's still very exciting in the adult world. We are seeing its use in the pediatric and adult world for refractory solid tumors, for high and low-grade gliomas and medulloblastomas. And it is, again, in research trials for many different types of cancers, including sarcomas in the pediatric world. The side effect monitoring for this medication includes high blood sugar, the electrolyte abnormalities due to its renal toxicity, hypertension, and then it is worth it to talk about the impaired wound healing for this medication. The one thing about its use of this medication early in cancer treatment is that we find that wound healing is a big factor. In fact, the warnings right now include some warnings that if you have to have surgery, you must wait 28 days after surgery to start the bevacizumab. So that is a long time, especially when we're considering in the pediatric world, a lot of our patients are getting ports. So they would not be able to start this medication early in treatment. And I believe in the pediatric world, that's why some of the medications in this category are being reserved for later in therapy and or for when there's refractory disease. The tyrosine kinases I've talked about earlier, and I will talk about again in a diagram that I'll show you at the end of this portion of the presentation. The medications in the pediatric world that all have angiogenic effects include sorafenib, sunitinib, axitinib, and pazatinib. Say those medications 5 times quickly. It's a killer, isn't it? Okay, next we're going to move on to the miscellaneous agents. Thalidomide is one of those miscellaneous agents. Many of us are too young to remember that thalidomide in the 1960s was prescribed by OBs as an antiemetic for their pregnant patients. What we all do remember is that the patients that received thalidomide had abnormal offspring that often had arm and leg abnormalities. That was a really sad effect that was found for thalidomide in the 1960s. Many people stayed away from that medication for a long time. But what was fascinating about it is it did show that it had anti-angiogenic and immunomodulating effects, especially the anti-angiogenic that occurred in the 1960s for the medication for the patients that got that medication when they were in their moms during their mom's pregnancy. We do know that it does block the vascular endothelial growth factor receptor, and in addition, we're also seeing immune effects on tumor necrosis factor alpha, and it may increase natural killer cells and IL-2 cells levels. So it currently has an orphan drug status. Very early in the presentation, I talked about the REMS program. We also have a REMS program for the thalidomide. It, again, can only be prescribed by physicians who have registered with that program, and then it can only be dispensed from pharmacies that are part of that program. The warning that I would give you is be careful in telling your patients you can start them on thalidomide soon, because it takes at least a few days, if not a week, to go through all the requirements for this program. The program is established or in place, again, due to the concern for using mandatory contraception in all patients who are childbearing ages, including males and females. Side effects of thalidomide that are common is neutropenia, which would be a reason to hold it, along with thrombocytopenia or other hematologic problems. It also can cause constipation. Some patients complain of pruritus or itching all over their body. Many times we don't recognize that right away as being a cause from the thalidomide because there are patients that are getting this are on other medications too, but something to watch out for. And then we do see some shortness of breath, the birth defects that we all know about, and also some pain and edema can occur with the thalidomide. The use of the thalidomide is generally for refractory cancers at this point in time, mainly because we're not really sure about its other effect as our children, as it's not been used in growing children. But if our patient has refractory disease, then it would be in place for that because that will help our patient to survive at least a little bit longer. One thing that we found with thalidomide is that there is a lot of resistance that seems to occur with it. So now out there we have lenalidomide that has been on the market. It is more of a multi-mechanism medication as an anti-angiogenic therapy, and it also does affect the immune system too in an immune modulatory way, and also can be an anti-neoplastic in its ability to kill cells. Right now, this also has an orphan drug status, so you do need to go through the REMS program for that, but it's being used for lymphomas, for leukemias, and for myeloplastic disorders. Side effects for the thalidomide is also dermatologic reactions, liver failure, thyroid dysfunction, so that would need to be monitored. We are worried about secondary malignancies for its long-term use, which we haven't established at this point in time, so that might be a restriction for the pediatric world. And then we do have multi-organ failure that can occur with it, and in some patients there may be a tumor flare, so that's something to watch out for in the first beginning of the use of it. As we move on, other anti-angiogenic agents, which I was surprised to find out about, vincristine and vinblastine are considered to be these because they also inhibit endothelial cell motility, proliferation, and migration. Taxol is another one that has potent angiogenic effect. And again, some of these we are using at very low doses to try and affect a metronomic effect. The angiogenic therapy that we talked about, I'll talk about a little bit more in the next few slides. There are some potential other uses for it in combination with other cancer medications. Curcumin, as we talk about natural substances for our patients, we may see a large increase in the number of alternative medications we are using, especially because many of them are found to have anti-angiogenic agents. And that also may include diet modifications to include some of the natural fruits and vegetables that are out there that can decrease blood vessel growth. Celebrex is often a medication that I'll recommend for pain in some of my patients because I also know that it will also possibly prevent the formation of new blood vessels in some tumors that overexpress COX-2 enzyme. And again, below we have a whole bunch of other natural substances. So, anti-angiogenic agents, I really thought that these were going to be the way of the future. And it's been a little bit of a downer to see how much that high expectation of these agents as they came out has now fallen the wayside. They especially are not used as single agents and are best found to be used in combination with other chemotherapy. There's two reasons for this. One is resistance. There are two mechanisms of resistance for the anti-angiogenic agents. They include adaptive resistance, which means that the malignant cells are able to cope with that lack of blood supply and either find other ways to get around blood vessel growth that's not part of the anti-angiogenic medication profile, and it also finds ways to overcome the hypoxia related to it. The other thing is, intrinsically, there are some tumors, such as some adult pancreatic tumors, that are able to grow without vasculature, and they have compensatory factors that allow them to grow without angiogenic concerns. The next thing that I'll talk about is, as we look at these agents, the proposed best therapy, again, is in combination with others. And that seems to be because they seem to work very well initially in the tumor because they help the tumor first to cause normal vascularization, which improves the intra-tumor perfusion. This can actually, in some ways, help the tumor because then the tumor can grow faster. But if we can use it at the correct timing, these anti-angiogenic agents can be used in combination with chemotherapy because they will help to improve the tumor perfusion of blood, and therefore the chemotherapy agents will have better penetration into the tumor and have better ability to cause cell death in the tumor. So there is a lot of studying now proposed for the future in the next few years to look at the optimal intratumor delivery period and how can we best use these medications to get the cancer therapy drugs that are going to kill the tumor to the right place. We're looking at the accumulation of the anti-angiogenic agents in these areas. Do we need to use them a week ahead? Do we need to use them a few hours ahead? How is that going to work in order to get our chemotherapy to the right area? So that will be the way of the future that you'll see soon. This next slide helps to kind of pull together a lot of the things I've talked about in this talk today about novel therapeutic medications for cancer treatment in the pediatric world. This is mainly from an article about anti-angiogenic therapy in pediatric brain tumors and whether or not it will be an effective therapy for our future. But this diagram from the article also helps us to see where these medications are having multiple effects. So, for instance, sorafenib, which is a tyrosine kinase inhibitor, multi-factor tyrosine kinase inhibitor, will have the effect early on at the blood growth or angiogenesis level in a few different places, looking at the vascular endothelial growth factor receptors and having an effect there. And then it will also have an effect on cell proliferation at some of the tyrosine kinase areas, such as the RAS area. So this kind of helps to pull together all these types of therapies that I'm talking about, and this also helps to show how all these different types of medications, especially the tyrosine kinase inhibitors, can be connected to have multiple effects on our cancer patients and their tumors. So as I come to the conclusion of my talk about novel therapies in pediatric cancers, I have this cartoon that shows the pharmacist giving their patient, in this situation, not a pediatric patient, but an elderly patient, a capsule. And he's saying your medication plus all the treatment for each of its side effects. And as we're looking at novel therapies in pediatric cancer, we're all hoping to find that magic medication that we can give to our patients that will affect the cancer and kill the cancer and cause the fewest side effects possible. Thank you for your time today, and good luck on your board exam. That is the conclusion of my talk.